I'm Shyam Panchal. I'm one of the stroke neurologists at the Methodist Hospital in the Woodlands. I just wanted to thank Dr. Volpe and in full appreciation of all the other speakers and physicians and everyone else and other providers speaking before me. We're kind of closing out on a different angle here and talking about burnout in neurology. Just kind of give it a little bit of background. I've just finished fellowship back in June and July, and have started practicing in the Woodlands. And this was part of my residency grand rounds as well. And so kind of carrying forward and discussing about burnout in neurology, I think is a good way to kind of close out where we are presently with neurology and where we're going in the future. And so with anything in terms of these topics, we'll kind of go over the objectives here. So we'll start by defining burnout and burnout prevalence in medicine, and then kind of going a little bit of detail in terms of discussing the different characteristics and contributing factors of burnout specific to neurology. Then we'll kind of go into how and by what means have there been established ways of mitigating burnout, and then where we're going in the future as well. So how do we define burnout? When we're kind of looking at what burnout is, it really helps to know what the defining features of burnout are to really kind of identify what the contributing factors to it are before we can kind of decide how to mitigate it. So not just defining it, but really kind of identifying the prevalence of it is important. And so burnout, in terms of literature and medical literature, has been sort of standardized into a couple of different scales. The most widely used scale is called the Maslach Burnout Inventory. Burnout as a sort of measurable qualitative and quantitative feature in medicine and medical practice really sort of bore out of an increasing symptomology of burnout amongst practitioners in the 1980s into 1990s. And this inventory and this scale came out in the 1990s. It sort of describes and characterizes and categorizes burnout into three respective subscales. And so looking at the domain of emotional exhaustion, which really kind of looks more towards depletion of emotional resources, where you're unable or you feel unable to perform at a physical or psychological level. Depersonalization, which is more so these negative, cynical attitudes and feelings towards patients, and then also reduced personal accomplishment, which is more so the sense of a negative sense of towards oneself when you're assessing your patients and really kind of your feelings toward yourself as you are working through your patients. It's become one of the more validated scales used in burnout measurements. There are a couple limitations on it by its length and its expense, but by most part, by and large, it's sort of the one that has been used in standard burnout literatures across the spectrum of specialties and subspecialties. And so diving right in terms of burnout across specialties, there was a survey conducted back in 2012 that looked at burnout and burnout indices amongst a spectrum of physicians. And so this was conducted across about 1,700 physicians across all subspecialties, and it looked at and surveyed physicians at a certain point in time. This is not necessarily a longitudinal assessment yet, but at a certain point in time in terms of assessing not just the different domains of burnout, but burnout as a whole, and then looking at the different subspecialties as well as to what subspecialty featured more of, or had more burnout characteristics and were associated with burnout more so than another one. And so in general, across all subspecialties, overall, we can see that burnout as a measure of having at least one burnout domain or identifying one burnout domain was prevalent across 45% of, or about 45% of physicians surveyed. The higher domains of burnout were identified more so in emotional exhaustion and depersonalization, and so the overwork and the workload leading to a emotional fatigue and sort of a step back from that emotional component of physicians towards their patients more so than that reduced level of accomplishment were identified across the spectrum. In terms of the respondents and the neurologic aspect of this survey, across the spectrum of physicians that were surveyed, 3.5% of them were neurologists. But then looking over here as much as we can in this this very minimized bar graph here, we see that neurologists came in third in terms of the prevalence of burnout across the subspecialties, coming in below emergency medicine and general internal medicine as well. And so although the neurologists in the survey were not as accounted for, their extent of burnout was certainly not unaccounted for. There was a longitudinal follow-up to this, so this survey was done in 2011 or 2012, and then there was a follow-up longitudinal analysis done in 2014, and what it ended up showing was that it was essentially more of the same or worsening of the same. And so the prevalence of burnout had worsened across all subspecialties as well. There was an association and a trend towards worsening of burnout as well across neurology too. And so in terms of defining burnout, through validated measurements, we identify and define burnout as at least having at least one symptom of burnout, emotional exhaustion, depersonalization, or a reduced sense of personal accomplishment, which has been found to be in at least half of the physician population. The prevalence of burnout is increasing across all subspecialties longitudinally, and then neurologically, in terms of the neurology subspecialties, it's disproportionately high compared to other non-surgical subspecialties and has been showing to have a trend towards worsening in time. So not to speak to just physicians alone, but going through medical education and coming from where I am as well, burnout was measured and has been measured and continues to be measured across medical students as well, and residents and early career physicians. In terms of specifically looking at this population of practitioners and physicians and practicing, or at least training physicians, the features of burnout were most prevalent during residency and fellowship, and then improved for early career physicians. And so this aspect of emotional exhaustion was most prevalent in residency and sort of that first step towards becoming a practitioner, but it was equally present in medical students as well. And then by the time that the physician graduated to becoming an early career physician, some aspects of that burnout had improved. And so it speaks to that aspect of burnout not being just initially once a practitioner is right out of the gate, but these symptoms of burnout really sort of being present and prevalent and ruminating and germinating early in the training of a physician and a medical practitioner, kind of just highlighting the importance of recognizing it such that it can be mitigated early on rather than suffering the consequences later. Kind of again speaking to the impact of burnout in physicians, this is me when I was a medical or a pre-med student. We kind of want to know, why is it important to measure burnout and really kind of define it? What significance does it have really in sort of the practice of medicine overall and medical training? And so how do we go from this to someone that looks like this is an important question to ask, and people like me want to know the answer to that. And so kind of going into the impact of physicians and speaking more towards neurology, we kind of saw that the identification and the prevalence of burnout in neurology was disproportionately high. And looking at sort of going back to the initial analysis from 2012, neurology was the third highest in the rate of burnout, but that study also showed that neurology was the only one to concurrently be amongst the lowest in the satisfaction of work-life balance. And so the significance of all of this is such that there's an association with greater burnout and risk of burnout that may be associated with physician shortages as well, such that early career physicians or medical students and students that are going into medical practice or training and aspects like that may recognize that there are certain fields and subspecialties that are more so associated with burnout, which may lead to a higher degree of poor work-life balance and potentially a loss of patient care or early dropouts and other consequences in terms of the physician's role and the physician's aspect itself. And so there are other studies that have looked at the psychological impacts and the psychological implications in terms of the prevalence and presence of depression, suicidal ideation compared to the general population. Aspects like that haven't really shown to be statistically significant compared to the general population alone, but that doesn't necessarily mean that that aspect of the psychological impact of depression or of burnout is not present. the satisfaction with work-life balance may inversely correlate with the extent of burnout in neurology. And again, depression may become more prevalent with time. And then kind of circling back to the overall impact of all of this is that the negative impact of burnout on physicians could also contribute to the overall physician shortage in terms of how trainees are perceiving more demanding subspecialties. And so how does this play out into neurology practice? We've been kind of hinting at how burnout is compared to other medical subspecialties and the medical spectrum in general. But what do we know about specific burnout in neurology? And so back in 2016 in AAN, there was a survey conducted across the spectrum of about a little shy of 1,700 practicing neurologists and subspecialtists in neurology, where it incorporated the MASLAC burnout inventory as well as a couple of other questions addressing and inquiring on burnout, career satisfaction, and overall well-being. They dichotomized the practitioners amongst people that were academic practice versus clinical practice neurologists. Most of the respondents identified as being clinical practice. A little bit shy of 40% were academic practice neurologists, and so the large bulk of this was from clinical practice providers. The most common subspecialty was epilepsy, accounting for about 8.4%, and then speaking specifically to us as stroke providers, vascular and stroke represented about 6.6% of the neurologists that responded. And so jumping into the meat of this, looking at the results of the burnout measures, overall about 60.1% of neurologists had at least one symptom of burnout, be it emotional exhaustion, depersonalization, or reduced sense of personal accomplishment. Clinical practice neurologists had a higher rate of burnout than academic practice neurologists, which was accounted more so by a higher rate of emotional exhaustion and depersonalization, which is really what we've seen from the earlier studies in terms of how physicians identify with and attribute their burnout factor to be towards. In terms of factors that are associated with burnout specific to neurology, and looking at a multivariate analysis of the data from this survey, the lower risk predictors were identified in blue here, and so identifying that were, in terms of having a lower risk of developing burnout, were greater autonomy and finding and having greater autonomy in meeting and work, having a reasonable amount of direct clerical tasks, and having an effective support care and supportive staff to assist with patient care were important. And then specifically looking at a subspecialty that was important, or a subspecialty that identified with less of a risk of burnout, lo and behold, was epilepsy. In terms of higher risk predictors, those were identified in red, and so looking at those would be more work hours per week, more nights on call per week, and more numbers of outpatients seen. And so the workload seems to identify and correlate and associate a little bit more towards the higher risk of burnout, and having a strong supportive staff and a bit of more balance in terms of the practice of neurology, just outside of just seeing the patient, but having the support there, seems to be associated with a less or reduced risk of developing and having and identifying burnout. So that's quantitative. Qualitatively, there was a concurrent study done and a companion analysis published with the qualitative, or with the quantitative aspect of this survey. And it was more so of a free text response to the neurology survey that looked for and identified different statements and themes that a respondent would identify in relation to their burnout and what they identified more so with burnout. And so 4 overarching themes were identified across 15 subcomponents, and those were policies and people affecting neurologists, be it the people in terms of support care staff versus governmental support and assistance and recognition. The workload and the work-life balance were important too. The engagement, professionalism, and work dimensions, and then solutions and advocacy played a part as well. And so kind of depicting this in terms of something that can be understood, a word cloud was generated from the responses in terms of the domains of the responses and what they represented in terms of a category. And so we see that positive comments are green, negative comments listed in red. The most numerous comments were more so negative remarks about workload, professionalism, government mandates, work-life balance, the electronic health record were other negatively identified themes. And so it really kind of very well depicts that the workload in terms of what the neurologist goes through is really sort of the bulk of and what contributes the most towards their identification with burnout. So we know this and we have this general understanding about burnout, what it is, what its prevalence is in terms of the medical practice and how it relates to and how it identifies with neurologists. What do we do about it? We have an idea about what's contributing, we know trends are going on, but what do we do about it in terms of mitigating all of this and having some form of relief? And so how do we go from this to a cool guy with hair again with a pretty girl by his side? And so there is some aspect of research that has been done in terms of how burnout can be mitigated in a structured fashion. And so older studies in terms of initially identifying burnout and looking at ways to mitigate it looked at or dichotomized it towards intrinsic factors versus extrinsic factors. And so most older studies looked at intrinsic factors where it was more so person-centric. And so looking at being focused on stress reduction, mindfulness, resiliency, without having an institutional basis where the initial responses and attempts to mitigate burnout. These studies were more so limited by small sample size, short follow-up, lack of true randomization. There was a shift towards, or from, not necessarily towards, but a shift from viewing burnout as an individual problem to a problem of the healthcare system as a whole. Rooted in things like working environment and organizational culture. And so ultimately through these small studies of intrinsic factors and mitigation of intrinsic versus extrinsic factors, a meta-analysis was done of different randomized controlled trials and other studies comparing these two as to whether or not there was different types of intervention, these physician-directed being the person-centric interventions versus organization-directed interventions, and the different characteristics of them, meaning that the length of the exposure to the intervention and things like that were assessed in this one meta-analysis that was published back in 2014. What it ended up showing was that the physician-directed interventions led to small, significant reductions in burnout, but there wasn't necessarily any evidence that the content or the intensity of the burnout or those interventions may have had an increase in the benefit. The organization-led interventions were more likely to lead to reductions in burnout as well, but there was nothing in terms of a standardized organization approach to where and what intervention tactics were used and the intensity of those such that anything widely implementable could be garnered from that. An overall intense organization level of intervention was rare at that point in time. What the authors of this meta-analysis really sort of deduce is that if burnout is a problem of the whole healthcare system, it's less likely to be effectively minimized solely by focusing on the individual level, and more so looking at a sort of standardized, implementable organization-led intervention may have greater, more sustained benefit in terms of mitigating burnout. So where do we go from here? All of these things were done in the 2010s and late 2014 and beyond. Where are we right now with burnout? With the COVID-19 pandemic and how it's impacted neurology specifically in terms of us not having any reduction in terms of the volume of patients we're seeing. If anything, the volume of patients are going up, and us having to mitigate and manage and change our approach to not just acute neurology but outpatient neurology as well. Where are we going with this? Kind of just to summarize before we discuss further, so we know that burnout is a syndrome of exhaustion, disengagement, a sense of accomplishment that is prevalent throughout medicine. Neurology is uniquely affected due to a high degree of burnout with low sense of self-satisfaction and work-life balance. Practicing neurologists and trainees share similar contributing factors to what makes their burnout worse. Organization-directed measures may result in more sustained reduction in burnout, but a standardizable, implementable organization-directed measure is really not yet available. And so kind of asking these questions, what are the neurology-specific interventions that are in place right now to address burnout? What do current systems address in terms of neurology physician shortages, and what are the means of addressing administrative impediments to burnout interventions? And so these questions are relevant regardless of the environment in which we're in. At the time that I had initially done this presentation in sort of a long-form aspect, specific to neurology, the American Academy of Neurology had different programs available that were associated with different academic institutions in terms of developing these organization-centric mitigating measures that included mentorship, conferences, and social activities that had some form of promise in terms of reducing burnout as a whole that were not necessarily independent of the independent measures. All of this has sort of changed with the way that we are having to practice medicine right now in terms of not only the extent to which the aspect of burnout is worsened amongst neurologists, be it the emotional exhaustion that we're experiencing from seeing these patients versus the depersonalization from having to see another stroke patient or another confused patient with COVID and having to kind of go through those measures. All of that has not changed. If anything, it's worsened, which is now complicated by the fact that these measures that were in place or that were being developed are now on hold or have been scaled back or are really not able to be optimized to their full extent because of social distancing guidelines and things like that, where a sort of group-centric approach is really not able to be well utilized, despite the whatever we can do in terms of virtual conferences and meetings and things like that. It is sort of a very unique situation to where the contributing factors to burnout have exponentially increased without an ability to catch up on measures that may have shown some benefit. And so we're at the point right now to where it is one of those things that does not necessarily have a correct answer to how burnout can be mitigated in neurology, given that this is sort of a live process right now. There are different means by which programs were in place to address this, but as to whether or not those play out with the changing times that we're in remain to be seen. These are my references, and thank you for your attention.